Welcome to Health Talk. Today we have with us Dr. Paul Wang, Professor of Medicine, Stanford University School of Medicine, Director of Cardiac Electrophysiology. Our topic today is sudden cardiac arrest. With us we have guest interviewers Evelyn Ross, Masters of Public Health, University of Iowa, and Veena Nam, Bachelor's of Science from Berkeley's School of Engineering. So, Dr. Wang, what about sudden cardiac arrest? I know it affects 350,000 people a year. It's a death that fills a jumbo jet of 747 passengers and affects all ages. What is it that we should know in America for our home audience?
Yes. Well, thanks so much for highlighting this topic. It's really of critical importance. I think one of the things that we know about sudden cardiac arrest is that the general public is really quite unaware. Anytime I talk to the lay public about sudden cardiac arrest, they really are really not able to really understand that it's such a major problem. The lay public has typically heard about, very important serious conditions, lung cancer, breast cancer, other major illnesses. But when they hear, as you mentioned, that over 300,000 people die every year in the U.S. alone of sudden cardiac arrest, they're really in disbelief. And so I think it's one area that we as a community, healthcare providers, are really focused on increasing the amount of awareness. So I think it's very important, first of all, that people understand and know about sudden cardiac arrest.
Now, both you ladies here are involved in an internet questionnaire looking at health screening, because in the 2008 Olympics, a marathoner runner died who was in his 20s, and it was thought to be sudden cardiac arrest. And in the 2012 London Olympics, a Norwegian swimmer died in the pre-Olympic trials, again thought to be sudden cardiac arrest. So obviously, there's not enough knowledge about it, and countries like Italy screen for it, whereas America does not. Now tell us a little bit about the questionnaire.
Well, the questionnaire that we're sending out right now is asking people about their awareness of sudden cardiac arrest, and then also if they've ever had symptoms that might lead to this condition, and if they did have symptoms, did they ever report them? Did they think it was a problem? Did they tell their coach? Did they tell their doctor? Or did they not tell anybody because why? We don't know the answer. But so that's the big question right now is, if you do have these symptoms, do you know that you're supposed to report them? So,
do you think that's a good idea to have a questionnaire like that?
Yeah, excellent. Well, I think it's really important to gather information about what the level of public awareness is, because I think it highlights really what we don't know about the general knowledge of sudden cardiac arrest, and then hopefully to come up with strategies where we can inform the public better, and then to be able to intervene and really have them identify people, and it would in fact improve our prevention of sudden cardiac arrest.
Now, the heart, for the home audience, is both a pump and an electrical organ. So as a pump, people think, oh, I have a clot, I'm going to get a stent, and it's like roto-rooter. The plumbing is fixed, and I go on with my life. Now, that's commonly thought as a heart attack, whereas sudden cardiac arrest is a battery problem of the heart. The electrical system of the heart is not working. So you're a cardiac electrophysiologist. You deal with the battery part, whereas the pump people, the people who do the roto-rooter, the stent people, they're different type of cardiologists. Now, showing this heart here, you have the heart model. That was so nice of you to bring it. Tell us about the electrical part of the heart, and how is that affected or plays a role in sudden cardiac arrest?
Yes, so that's great. That's a great question. So first I might use the heart model to illustrate really how the electrical and pumping functions of the heart come together. So what we know is that the heart impulse starts in the right upper chamber, and that's from the heart's own pacemaker, we call it, and that's the sinus node. So the impulse starts there and then travels through the rest of the heart, traveling initially through the right atrium and to the left atrium, the upper chamber of the heart on the left side. And then additionally, it will travel from the top part of the heart, we say the top floor of a two-story building, to the bottom floor of the two-story building. And those are the main pumping chambers and those are the right and left ventricles. So the right and left ventricles do the pumping of the heart, the right ventricle pumping the blood to the lungs, the left ventricle pumping the blood to the entire body. So the initial importance of the electrical signal is paramount, because the heart needs to know when to in fact perform these functions. And so properly timed, we have a really perfect coordination of events. It's a ballet in itself that the electrical signals can coordinate what happens in the top chambers and the bottom chambers. And
now
so this is the importance of the electrical system. So one can also see from the inside of the heart the same kinds of features. The upper chamber on the right side, where the impulse electrically starts, traveling through the specialized heart cells that are responsible for carrying the electrical signal. The AV node, which connects the top and bottom floor and then causes the electrical signal to get to the bottom heart chambers. So we have therefore a very particular sequence of events, a series of timing. So much like your spark plugs operate in triggering the pistons of your car, the electrical signals cause the heart to contract in a very particular and coordinated manner. And so this is the essential importance of having a correctly operating electrical system of the heart. And indeed, this relates directly to our discussion today of sudden cardiac arrest.
So what happens in sudden cardiac arrest and the electrical wiring of the heart?
Yes. So the importance of understanding it is really, it comes from the change of who's in control of the heart rhythm problem. So as long as the electrical system, as we've described it, normally operates, starting very methodically from the upper chamber, traveling through the specialized conduction system, and then going to the ventricles and spreading in a very uniform fashion, much like when you drop a pebble in a pond, the waves come very smoothly and regularly outward. We can have an electrical system that does the same thing. In rhythm problems of the lower chamber, we call ventricular tachycardia or ventricular fibrillation, there is an entirely different series of order. And so that degree of disorder is what causes this problem. In the case of ventricular tachycardia, some people will abbreviate that VT, that an area within the heart, the lower heart chambers, typically the left ventricle, but also occasionally the right ventricle, can cause a circuit of its own to occur. So you very much have like really an invasion. You have a series of electrical signals that then start on its own in the lower chamber, therefore superseding what has happened in the normal electrical pattern going from the top to the bottom. So that ability to take over, supersede the normal conduction, then allows the ventricles to take over and go at their own rate very rapidly.
So like, to make it simple for our home audience, if you have the upper floor and the lower floor of a house, and the middle is the conductor, so what happens, it's like a concert chamber, like if you have a bunch of people on the upper floor and a bunch of people on the lower floor, but in ventricular tachycardia or ventricular arrhythmias, the conductor cannot do the entire symphony anymore. This runaway renegade group decide to do whatever symphony they want to do. And that symphony causes the sudden cardiac
precisely correct. And so we have that additional, that area which takes over. And so the extreme of that, really the absolute extreme of disorder, is called ventricular fibrillation, also called VF. And ventricular fibrillation is that ultimate degree of disorder within the left ventricle. So the signals absolutely do not have any respect of control. They're rapidly circulating among the cells of the left ventricle and the right ventricle, and therefore we've lost total control. And so what happens as a result of the electrical signals being out of control, the muscle part of the contraction no longer has any ability to be coordinated, because our very existence depends on the ability of heart cells within the pumping chambers to fire in a very specific order so that we can get pumping. So that is what allows us to pump the blood. If all the signals are firing at different times and are not coordinated, the heart function stops, meaning that the electrical signal is going on, but you cannot coordinate it, so it cannot pump in an effective manner. So one loses blood pressure immediately, loses perfusion to the brain, and unfortunately death will ensue unless this is corrected very, very rapidly.
Now, in those athletes who died suddenly, we did a study like 5 years ago, and we did a giant internet study, and we found that the marathoners knew more about sudden cardiac arrest than the rest of the population. Even though the actual incidence of sudden cardiac arrest is actually very low per marathon. So let's say you're a young, healthy person, and you've always been young and healthy, and then suddenly you're 21 years old and you collapse and you die. Now, it apparently, at marathons, I don't think they have AEDs, automatic external defibrillators, along certain points. Is that true? I don't think that's required. Or
yeah, very good question. First, in terms of athletic performance, so we know that the incidence of sudden cardiac arrest in young, healthy individuals is quite low. However, there is a lot of knowledge now about the incidence in events such as a marathon, because you're bringing together a large number of people, tens of thousands of people typically, and they're going from an extended period of time. So the number of people hours is actually very high. So you're looking at a fairly high number of people undergoing probably pretty extreme degrees of exertion. So it's not unusual that at a large marathon that there will be a collapse in that kind of situation. Now, we hope that indeed, as we'll talk about it in a few minutes, that the response is rapid. Because one of the things we do know about sudden cardiac arrest is that the ability to resuscitate the patient is dependent really largely upon the ability to treat the patient immediately. And so that immediacy of the treatment really determines the ability of success. So so that is a really important feature of when we look at people such as involved in large athletic events such as a marathon.
now, you were an All-American honors in track and field. What does that make you think about sudden cardiac?
You know, this has been a really interesting thing for me to learn about, because actually in all of my time as an athlete and then later as a coach, this wasn't really on anybody's radar, I would say. We didn't talk about it on our team. The coaches didn't talk about it. And I don't think it ever came up, you know, in sports physicals or, you know, with your athletic trainers. And so I really think, you know, from an athlete's perspective, like, you know, I didn't know very much about it, and that concerns me.
However, you did have a required physical in college.
That is correct. Yeah, that is correct. We every year you had to have a physical. However, you know, there's different levels of physicals. Do you get it, you know, at your primary care doctor back at home who you've known for 20 years, or do you, you know, go to a one-day clinic where they're just rushing through, or do you go to your trainer, you know, and, you know, so you don't know how thorough these things are, and also, is there screening for this type of thing in the physicals? They ask you questions, but that's about it.
Right, there's no kind of required one question that everybody asks. You know, that maybe, I don't think the American Heart Association or the Heart Rhythm Society has said that this is the 2 recommended questions to ask for everybody who's an athlete. Those are kind of interesting, you know, thoughts about.
Yeah. So there have been a variety of approaches, as you have indicated, to the process of screening. So different organizations have embraced different recommendations. Largely, it does the uniformity is that there is a physical examination and there is some form of a questionnaire, a medical series of questions that are asked of the individual athlete. And so in doing that, that forms the majority of screening processes in the United States. So, for example, the Academy of Sports Medicine, Academy of Pediatrics, they've all embraced this idea that, in fact, there would be this 2-component strategy for screening, a history and a physical examination. What is somewhat variable, both in terms of requirements or guidelines as well as practice, as you indicate, is who does that. Is it a physician, a trainer, what other, a team nurse or other coach that would perform that? Who in fact would it be? But generally it's a trained healthcare provider that would do both the history and the physical examination. But as you underscored, I think the approach of the athlete is often that obviously people are very motivated to participate and very much maybe not as aware of really what the importance of the screening tool is. So sometimes you may not know, for example, or recognize what symptoms you might have had. A period of dizziness that at one point might seem very innocuous could in fact be a clue to the need for further evaluation. Similarly, quite importantly, I would say, would be the knowledge of family history. So for the most young individuals, they may know very little about the family, their medical history, and whether there has in fact been a family history of collapse, sudden cardiac death. One of the things that I find in my experience that leads us to not recognize risk is that a family member has been told that they had a heart attack. And so that indeed, if the person died suddenly, for example, might have been labeled as a heart attack, but in actuality it was sudden cardiac arrest. So that would be one example that we would encourage the general public to become more aware of their family history, what in fact in particular might be a family history of sudden death, and ask more. How did my uncle die? Did he die suddenly? Particularly if it occurred at a younger age, meaning age of 50 or less, and if so, therefore, what evaluation there might be. It might be the most important, really, piece of information for the entire family's health that one might obtain. So these are some of the ways in which I think we can enhance the value of screening, even as it's done today in the United States. So I think we have really both hope and optimism with greater degrees of awareness that the general public will get behind this. These largely are areas where many community members do get involved. That is, they're involved in the sporting event, they're involved in sports teams. So I think both parents and other individuals might take the charge, as they have done in many communities, and develop their own screening tools, their own screening programs that may in fact highlight some of these findings and some of these areas to be concerned about.
So you think the two most important questions to ask is family history and if they ever had any symptoms?
Yes, so most of the questions on most questionnaires center around these things. So symptoms, chest pain, fatigue, shortness of breath, dizzy spells, passing out, those kind of typical questions would be really central, as well as any other known illnesses that they have, and certainly any information about their family history. So those would be the kinds of things that we would highlight in looking at the history-taking part of the screening process.
Now, if someone collapses and they're in the middle of a sporting event, and here there are trained providers there, because most marathons have doctors and nurses and healthcare professionals, and also calling 911, you have people there. There usually is an automatic external defibrillator at the main tent or in all ambulances. So what is it that people will then undergo? How are they going to know that this person just doesn't get classic CPR, which is you breathe and you pump on their chest? Tell us a little bit about that.
That's a great question. So one of the things we've learned is the response needs to be rapid. There really cannot be any hesitation in response. So the idea of thinking, oh, it might be something else, is a real delay in time. I think what we really encourage people, if they're unresponsive, that is not immediately waking up and getting up on their own power, that should be assumed to be a cardiac arrest until proven otherwise. So we call for the AED, get the first person who has access to it to arrive on the scene, provide it. That becomes a very important first step.
Now, there's a nomenclature or a terminology, fine line, when the public says heart attack and sudden cardiac arrest? Tell us. There's a fine line difference.
Yes. So again, heart attack really means that we know the mechanism, that is typically caused by a blockage in an artery, and often or typically does not result in sudden death. The occurrence typically results in hospitalization, may result in other treatments, etc. Whereas we know a sudden cardiac arrest really is characterized by a sudden collapse and typically immediate death or, in fact, resuscitation.
So in sudden cardiac arrest, where it's an electrical problem versus heart attack, which is a pump problem, in sudden cardiac arrest, you would expect the person to collapse and be unconscious. Whereas in a pump problem, where it's a partial clot, they're somewhat conscious. They're conscious, and there's time to get them through the stent, whatever intervention the cardiologists have for them.
Yes, exactly. While there are situations that heart attack can lead to sudden cardiac arrest, in fact, that is one of the most common presentations of sudden cardiac arrest is it can be started by a heart attack. The other occurrences really are separate from that there is an underlying heart condition, which may have been a previous heart attack or not, or another form of condition, and that causes the electrical signal abnormalities and leads to sudden cardiac arrest. So one of the things that as we think about screening that we need to consider is what are the different conditions we're looking for? How prevalent are those conditions and how might we best find them? So one of the things that also I'd like to highlight to the general public is really some of the conditions that are most well known as causes of sudden cardiac arrest in both younger patients as well as older patients. So indeed they stratify in that way. Above the age of 50, the most common cause of sudden cardiac arrest by far is coronary artery disease and heart attack. So a patient may have had a prior heart attack, but then because of the prior heart attack is much more likely to develop the rhythm abnormality of ventricular tachycardia, ventricular fibrillation, meaning that once they've had a heart attack once in the past, it makes them much more likely to develop ventricular tachycardia or ventricular fibrillation in the future. So that recognition is quite important and represents a large number of sudden cardiac arrests in the United States and throughout the world, and is the number one as the cause over the age of 50. Now, when one looks at younger ages and one looks at patients that in fact are younger, 40 or less, for example, the proportion changes dramatically. So the number one cause in the United States is a condition called hypertrophic cardiomyopathy. So hypertrophic refers to the fact that the muscle itself, unlike a normal muscle, which is typically a centimeter or less in thickness, is considerably thicker. And this is a genetic condition, one that is inherited and that produces this increased risk of sudden cardiac arrest. So well recognized. Now, we know that 1 in 500 individuals throughout the world, and every ethnic group that's been looked at throughout the world has really the same odds of having hypertrophic cardiomyopathy, and that's 1 in 500. So you might say in your high school class, there may have been one person who has hypertrophic cardiomyopathy. Fortunately, not all patients with hypertrophic cardiomyopathy are at the same risk of having sudden cardiac death. But we know that once they do have hypertrophic cardiomyopathy, they are at higher risk. So we would then want to make the diagnosis, want to counsel the patient and the patient's family appropriately, and then provide guidelines and further investigation as to whether we think they're at higher or lower risk of having sudden cardiac arrest because they in fact have hypertrophic cardiomyopathy.
So if 1 in 500 people have this, and if you have hypertrophic cardiomyopathy and you are increased sudden cardiac arrest, what is the percentage? What is the risk? So let's say I have cardiomyopathy. What's my risk?
Yes.
Is it increase if I do exercise?
Yeah, so it's a great question. So we know that the highest risk of sudden cardiac arrest in patients with hypertrophic cardiomyopathy is typically one is in your first several decades of life. However, in careful studies that have been done over time, that risk continues with every decade of life. It never goes away entirely. And so, in fact, so it remains an important cause of sudden cardiac arrest, regardless of one's age. So that's an important factor to keep in mind.
So if Vina, who's this young, lovely person, has hypertrophic cardiomyopathy, as she grows older, she will have a slightly increased risk, whether or not she exercises or not?
So, so the risk is maintained even after the initial higher risk period in young individuals, based on our information that we have. We do believe that patients who have hypertrophic cardiomyopathy are at higher risk for particularly peak forms of exercise. So there are very specific guidelines which are available by your physician who can guide you once you have the diagnosis of hypertrophic cardiomyopathy. One important consensus statement we call the Bethesda's consensus statement, in fact, outlines those kinds of activities that are allowed or not allowed in hypertrophic cardiomyopathy. Typically the most demanding exertional capacity requiring athletic events and sports are not permissible in hypertrophic cardiomyopathy because of that increased risk.
We have 2 minutes or 1.5 minutes remaining for this fascinating topic. So the take-home message, what would you like the home audience to know?
Terrific. So really awareness and participation. So I would like the general public to be aware of the condition so they can counsel their own family members. So if they're going to be screened, to take that seriously. So they ask their children, okay, are you having your screening this year? What does that involve? Also to support, participate, create awareness, support AEDs, automatic external defibrillators, which are really one of the major advances in this. Also identify heart conditions. So if you have a heart condition, find out whether that person should have a special device called an implantable defibrillator that may reduce their risk. So those are the various components that I would want to underscore.
Thank you very much for joining us, Dr. Wang. Thank you to the home audience for listening to us for our Health Talk. And if you like us, donate to KSAR TV. And if you like this show, go to YouTube. Thank you very much.